Welcome. My name's Caroline Hodd. Some may know the surname, some may not. I work for No7 Contact Lenses. I work in hospital practice. I work in private practice in a contact lens specialist practice. And do you know my dad? Yes. He's very jammy. Right, okay, I'm going to talk to you about the ICD lens, which is our new product from No7, and it's a 16.5mm mini scleral lens. So what's different about the ICD than other scleral lenses that we all know about? Well, the difference is that it uses the latest research on the limbal and scleral shape, research done by Caroline and van der Walt. And they've used this research to then redesign the edge profile of the scleral lens to make it different from scleral lenses that came before and make it a lens that fits a lot better the shape of the eye. The difference again with the ICD is it's made from a very high decay material. It's 100 decay, which means there's no need for a fenestration to let air in. There's enough decay to let the air through the lens. And the third thing that's different is it has a very simple fitting strategy. There's 14 lenses in the set, and they're all of different depths, and that's how we fit it. So it's very easy and logical. So what Eve and Pat found out is that the way that the limbus and the cornea changes into the sclera is not a limbal curve and then a scleral curve, but it's more like a straight line. It's tangential. And they've used this information when designing the ICD lens. The actual ICD lens itself lands at 15 millimeters. So although it's 16.5 millimeters in diameter, actually lands at 15 millimeters. And the reason they picked 15 millimeters is because this is the distance, the kind of furthest they could go, which minimizes a toric sclera. So if you go further, so if you go bigger, say 18 millimeters, 22 millimeters, like some of the sclerals we use, you're more likely to find the toricity of the sclera. So 15 millimeters has been optimized to fit the sclera. And the edge design, so where the scleral landing zone of the lens has been completely designed, is different from what you'll find on any other scleral lens. And I have found that that really reduces the digging in of the lens and solves some of the problems we had with scleral lenses. So the ICD is actually for all irregular corneas. So for keratoconus, for pellucid marginal degeneration, for those people who've had a graft. And also we found now that by providing a tear reservoir, we can use scleral lenses quite successfully for those people who have ocular surface disease, dry eye or Sjogren's that I've spelt wrong, as usual. So why should we go big? Well, if we go big with our lens, we can actually vault the irregularity itself. And this is good for the health of the eye, so we don't rest the weight of the lens on the cone. It's also comfortable. Big lenses are comfortable not because soft lenses are comfortable, not because they're big, because they're soft, but actually because they're big. So a big lens is far more comfortable than a small lens. So they should be comfortable from the outset. And they should center well because they're so large, which is a great benefit. And they're easy to fit, much easier than you would expect. And I wanted to go back and talk to you about what we've been doing before. So we've been fitting our keratoconics with a corneal RGP lens. And as you can see, if you try and put the lens onto the cone, you're fitting the cone, you're not fitting the eye. So most keratoconics, their cone is not central. So if the cone is inferior, your RGP lens will sit low. So the optics of the lens is not over the visual axis, so you get loads of aberrations. And also you're resting the weight of the lens on the cone, so you get scarring. And then the curvature of the lens, because it has to fit the curvature of the cone, can become very steep, and the power of the lens becomes very high, which also introduces more aberrations. If you fit the eye with a large lens, what you can do is completely vault the irregularity, so you're not touching it at all. Your lens is centered, and the visual center of the lens is over the optical center of the eye, the visual axis, and you might well get better vision than you would with an RGP2. So it had lots and lots of benefits. But when we fit a big lens, we're not fitting the central Ks anymore. In fact, we don't even really need to know them. We're fitting the depth of the eye, the sagittal depth. And even in the old days, got a few older practitioners like my father over there. You used to fit soft lenses using sagittal depth, and you may have heard Eve, middle-aged, Eve earlier on, talking about how they may now start fitting again soft lenses using sagittal depth. But for large lenses, you have to fit using sagittal depth. So there it is, at the diameter of the lens, it's the height of the lens, the depth of the lens. So then the real question when you get your patient is not what's your topography, what are your K values, it's how sticky out is your eye, how deep is your eye. You don't need to know keratometry values, you don't need even to do topography, you could do it without. You don't need to steepen or flatten your lens, you only need to go deeper or to go shallower. So you don't need to worry about base curves and diopters and all that sort of thing. And the lenses in the ICD set have a linear change in depth. Whereas when you fit an RGP lens, you change the curvature, the depth of the lens doesn't change linearly. So unless you have a Ken Pulham set. Okay, so here is the ICD. In the set you've got 14 lenses going from a low depth to our highest depth. Our highest depth is 5,600 microns. That's actually 5.6 millimeters deep. That's going to fit over our most sticky out, deepest eyes, our largest cones. And what Eve and Pat Caroline have also found is actually if we took everybody in this room who's got normal eyes, probably the same lens in the box would fit all of us, because the depth of our eye is about the same. We're pretty similar. So for normal eyes, you would start with the 4,200 micron sag, and maybe your very early keratoconics and some of your graft patients. If I want to know how sticky out your eye is, I can stand next to you and literally have a look. You know, if it's really sticky out or not sticking out, looks almost normal. You can have keratoconus, have terrible vision because your cornea is irregular, but it may not actually stick out that much. So that's a really good way to gauge. If you think they've got medium sticky out eyes, so they've got keratoconus, pellucid, they may have a corneal transplant that's sticking out a bit, you can start with a lens that's a little bit deeper. If they've got super sticky out eyes, so massive Munson sign, you can then fit with an even deeper lens. And only for your most difficult patient, you would go with the deepest lens to begin with. You can use a topographer, you can't use keratometry values, but if your topographer can give you elevation data, so it can tell you how deep your eye is, you will be able to use that to help you to choose your starting lens. And I think in the future we will have a machine that will tell us the depth of the eye right out into the outskirts, and maybe even we'll order our scleral lenses empirically. So we'll fit our keratoconics by doing a scan, and then we'll order a lens. No longer an art. And you can do this if you take the data at 10 millimeters, the height data, you can add on a scleral sag factor of 2,200 because we're all about the same. And then you add on 300 microns because you're going to give your lens some clearance. And the Medmont topographer actually comes with software that will help you to do that and help you to pick your first trial lens for the ICD lens. So when we put the lens in, and I may have a victim, I'll see if I can find him later on to put a lens in. We put the lens in filled with saline and filled with some fluorescein in it. And what we're looking for with the ICD lens is a 300 to 400 micron clearance. And we're giving it that clearance because the scleral lens is resting on the conjunctiva and it may well settle back because it's quite squidgy. So we give them a lot of clearance so that it has time to settle and won't land on the cone. So we can see if it's enough clearance. If we look, there's so much fluorescein, we can't see the pupil there. So that's one of the first things we look at. The second thing we do is we do an optical section. The thickness of the lens is 300 microns in the trial set. They're all 300 microns. You can compare that thickness to the thickness of the tear film, and then you can see if it's the right thickness. Now, fluorescein has a maximum fluorescence. If it gets thick enough, it won't shine any brighter. Okay, so you need to do the optical section to actually see how much fluorescein you've got there. You could have 800 microns or 300 microns and it would look the same front on. I'm sure lots of us are very experienced at doing this. So the way to tell if it's not clearing enough is if you can see the pupil, there's definitely not enough fluorescein there, not enough clearance. And if you've got any bearing on the cone, you also need to go deeper. And in our optical section, we see something like this, a very thin fluorescein layer. Once we found the lens that we think is the right depth, so if we see bearing, we increase the depth. If we think our tear reservoir is too thick, we decrease the depth. How logical is that and how simple? We don't have to think about base curves or anything like that. And we've done our over-refraction. The only other things we need to consider are, first of all, the limbal clearance, because the limbus is where all our lovely stem cells are. And we don't want to be squashing our lovely stem cells. So if you look at the limbal bearing zone and you see bearing of the lens, when you order the lens, you say, can I have it with increased limbal clearance? As simple as that. So that's the second thing we have to assess. And if we look at the lens out to the scleral landing zone, if the lens is landing too heavily, you'll see that the blood vessels that go under the lens will be blanched because they're getting squashed. And then we just ask the lab to give it to us with a flatter scleral edge. So you can fit your keratoconic in literally 5 minutes, less sweat. The only issue is you will get a lot of fluorescein on the floor. And you may be caught by your manager kneeling on the floor in a weird position with your patient. So you must prepare them first. So I think the whole theme of today for number 7 is that sagittal depth is the way forward. Large lenses fit this sagittal depth of the eye. You don't need to know the central case. You don't need to worry about them anymore. And this makes fitting more logical, quicker and easy. So the 3 lenses from number 7 that perform this function, the ICD that we've talked about today, the So Clear, which is about to be relaunched, which is a corneo-scleral lens with a new fitting philosophy based on sagittal depth, which will make your life a lot easier. And the Ultra Health lens, which is the hybrid lens, which has been launched last night, I think. And this afternoon at 4:10, you can hear all about the Synergize Ultra Health lens. There we go. Thank you. Thank you very much. I'm looking for my victim, because he said earlier, I want to... Oh, he's here. Would you like to see me put one in a innocent, a neophyte? Excellent. Okay, I have... So we're assuming that he's normal. We can't be sure.
Here we are, sir. Thank you.
I'll give it a clean just for you.
Do you need to use any different cleaning solutions or anything?
Crystal cleaner is very good. You can treat it like any other RGP lens. You don't want to use something with the beads in it, the polymeric beads. Okay.
What about if you wanted to clean your trial set?
Well, then you have to follow the college guidelines, or not.
Right, you can use.
Yeah, sodium hypochlorite. Yeah, it's absolutely. Oh, you've got tissues. So there's a 5 tissue rule. Your patient needs to have 5 tissues.
Not a white shirt.
And a white shirt. Exactly. Sometimes it's good not to show them it first. Will you open a fluorette for me?
Yeah, of course.
I always get the patient to open the fluorette for me.
Make him feel...
Important. Thank you. Okay, so one of these little inserters is really useful for holding the lens, so you don't have to balance it on 2 fingers, and when you get shaky, you don't spill all your saline. Okay, so the patient looks straight down at the floor, and they do the bottom lid for you. You do the top lid, and you just literally look at the floor, brilliant, bring it up, place it onto the eye. Like so. Oh, I got a bubble in it. I can't believe it. That's never happened to me before.
The sag is, could be...
A little bit too great. I should be able to get any lens in without a bubble, to be honest with you, because it was filled with saline.
I don't use any contact lenses, and
Well, I see the bubble.
Yeah. But what you've got to think is this man is now wearing a rigid contact lens and he's completely comfortable. And you know the first time you put an RGP lens, it's for a poor keratoconic who's atopic, who's really sensitive, very, very frightened, that you're going to torture them. But when you insert a scleral lens, you know that actually you're probably going to give them good comfort from the outset. If you do get a bubble in the lens, you need to take it out and insert it again. So out of 10, comfort?
It's getting even greater than in the beginning.
Brilliant.
As I told before, I don't use any contact lenses, and but I know that this kind of lenses are extremely, but it's very comfortable.
Good. If you turn straight ahead, you can also use one of these blue torches to assess the lens before you get onto the slit lamp. And of course, we've seen there's a bubble there, so I know I can take it straight out and put it in again. Okay, should we take it out? That's the fun bit. So you can either take out with a sucker, or you can take out the sort of tiddlywink method.
It's
Really quite comfortable. Good. So don't say that, understand. Have a look straight ahead. Brilliant. And I'm just pushing at the bottom, pushing at the top, and out we go. Okay. Thank you very much. You want another tissue?
You don't want to try another one?
No, fine.
Thank you.
Thank you. Any questions? No questions? Yes.
If you put it on a patient who's not got a compromised cornea,
Yes.
an average patient, is there any, what sort of wearing schedules and how long can they wear the lenses for? Are there any problems with because obviously you've got a good decay in the material, but you've got quite a lot of
tears
tear
underneath. And I agree with you. And that, I mean, Pat Caroline spoke last year. Oh, he asked, is there any problem if you wear the lens all day? If there's a very thick tear reservoir, although there's a high decay, is there enough oxygen getting through to the cornea? Pat Caroline spoke, I think, last year at the BCLA, and although it doesn't meet it's Holden-Mertz criteria, isn't it, for the amount of decay, they haven't seen any hypoxia issues. But I agree with you, and I think, you know, it may be that the lens material will become a higher decay in the future. But so far, that hasn't been an issue, and they should be able to wear the lens all day. There won't be tear exchange, particularly under the lens, because obviously the full landing at the sclera will not permit tears to get underneath. And in the same vein, sometimes the tears can mist up, and you need to take the lens out and clean it and put it back in.
So for a normal person, how long could they wear it a day?
I think they could wear, you know, from morning to night. Yeah, absolutely. Did you say there was another question? Oh, no, you said repeat the question. Thank you. Okay, thank you very, very much.